Welcome to This Explainer. I am so thrilled you're tuning in today because we are setting the stage for a truly fascinating deep dive into a rare, high-stakes clinical puzzle. We're going to look at a crazy condition where the human body creates an incredible anatomical shortcut with disastrous consequences. But more importantly, we're going to explore why solving this massive physiological crisis actually requires a surprisingly minimalist surgical fix. It's a perfect example of how, sometimes, doing less is exactly what saves a life. Let's get right into it.
Picture this. You're in the ER. An 80-year-old female patient rolls in. She is frail, she is incredibly sick, and she's showing all the classic signs of a mechanical small bowel obstruction. The junior surgical intern evaluates her and, naturally, wants to fix everything. The intern drafts up this aggressive, multi-step surgical plan to tackle every single anatomical defect they spot on the scan, all at once. But the senior surgeon steps in and immediately halts that plan. You might be wondering, why? Why is doing too much surgery in this specific bowel emergency actually fatal? Well, to find out, we need to act like detectives.
Section 1. The Clues. Decoding Rigler's Triad.
Okay, let's dive into this. Every medical investigation starts with imaging, right? Looking at this patient's CT scan, we see Rigler's Triad, which is a set of 3 highly specific radiological clues. First up, we see gas in the biliary tree, also known as pneumobilia. Normally, the biliary system should be filled with fluid, not air, so seeing gas here tells us there's an abnormal connection to the intestines. Second, we see a dilated small bowel. This confirms the mechanical obstruction, because everything upstream of a blockage just balloons right out. And third, the smoking gun, a large calcified density impacted far away in the right lower quadrant of the abdomen. Wait, a gallstone? That is nowhere near the gallbladder. How on earth did it get all the way down there?
Section 2. The Crime Scene. Anatomy of a Fistula.
To figure out how a gallstone manages to escape without traveling down the normal bile ducts, we have to look at the condition itself, gallstone ileus. Now, despite the name ileus, which usually implies a sort of functional paralysis of the intestines, this is actually a true mechanical small bowel obstruction. It's caused by an impacted gallstone that literally eroded its way out of the gallbladder and carved a brand new tunnel straight into the intestines. We call that a cholecysticertic fistula. Think of it like a massive boulder eroding through a mountainside tunnel, dropping directly onto a narrow highway, rolling down the road, and eventually wedging itself tight to block all downstream traffic. It's a total roadblock.
But this tunnel, it doesn't just form overnight. Let's walk through the silent, chronological timeline of this structural failure. For years, this patient suffers from chronic cholecystitis. That's persistent inflammation of the gallbladder that makes it scar and stick densely to the bowel wall right next to it. Over months, the pressure from a large stone, combined with all that intense inflammation, basically chokes off the blood supply. This leads to tissue necrosis, dead tissue. Then, over weeks, that dead tissue gives way entirely, forming the actual fistula, the abnormal tunnel. Finally, over just a few days, the stone erodes completely through this new path and drops freely into the bowel.
So, where exactly does this rogue tunnel lead? Well, in 85% of these cases, the tissue necrosis creates a very specific connection, a cholecystoduodenal fistula. Because the duodenum sits right next door to the angry, inflamed gallbladder, it takes the absolute brunt of the damage. The stone drops directly into the duodenum, completely bypassing the narrow bile ducts. And this is exactly why the patient didn't show the usual signs of jaundice or biliary blockage. It took a shortcut.
Section 3. The point of impact. So the boulder is on the highway, but before we track its path, we really need to appreciate the sheer size of this culprit. For a gallstone to actually cause a mechanical blockade in the intestines, it has to be massive, typically greater than 2.5 centimeters. Smaller stones? They'll usually just pass harmlessly through the digestive tract and be excreted. No big deal. But a stone larger than an inch? That is a formidable, dangerous physical obstacle trying to navigate a winding, narrowing tube.
And where does it inevitably get stuck? About 60 to 70% of the time, let's call it 65% based on the impaction data. The stone travels distally until it slams right into the narrowest anatomical bottleneck in the entire gastrointestinal tract, the ileocecal valve. This is the super tight doorway where the small intestine transitions into the large intestine. A 2.5 centimeter boulder simply cannot squeeze through this valve, creating a catastrophic mechanical roadblock for everything behind it.
Section 4. The Resolution. The Surgical Dilemma.
Which brings us right back to the reality of our 80-year-old patient in the ER.
Remember that ambitious intern? The one who wants to take out the gallbladder, sew up the duodenum, and cut out the blocked piece of bowel? Stop. Seriously, that instinct, while totally well-intentioned, is incredibly dangerous. Doing an emergency cholecystectomy, a fistula repair, and a bowel resection all at once in a frail, elderly patient carries a staggering mortality rate. It's just too much trauma. The true gold standard protocol here, enterolithotomy alone. We just go in, open up the bowel, and take out the stone. That's literally it.
But wait, I know what you're thinking. What about the hole between the gallbladder and the bowel? What about the diseased gallbladder itself? Well, here is the brilliant logic behind leaving the fistula and the gallbladder completely alone. Up to 50% of these fistulas will actually resolve spontaneously. Yes, on their own. Once the downstream obstruction is cleared and the internal pressure is relieved, the body's natural healing processes take over. By doing less, you minimize the surgical trauma and give this critical patient the absolute best possible chance to survive the immediate, life-threatening crisis.
Section 5. Essential Bedside Wisdom.
Now that we understand the minimalist strategy, let's step directly into the operating room. There is a classic piece of surgical wisdom when dealing with gallstone ileus, and it's summarized perfectly in 3 simple words: milking the stone. When the surgeon finds exactly where the stone is wedged tightly into the bowel wall, they do not immediately reach for the scalpel. Instead, they gently propel the impacted stone backwards, moving it away from the site of the blockage.
Let's walk through exactly how this looks in practice. Step 1. Milk the stone proximally. You push it backwards, up into the dilated bowel. Why? Because the bowel wall where the stone was just stuck is swollen, it's ischemic, and it's heavily damaged from all that pressure. If you cut right there, it will not heal and it will leak. Step 2. Perform the enterotomy, the actual cut, in the healthy, pink, well-perfused bowel tissue you just pushed the stone into. Extract the stone safely. And then comes step 3, which is absolutely crucial. You have to inspect the entire small bowel from top to bottom.
So the crucial point here is the search rule. You must follow it. While 90% of patients won't have a reoccurrence, a very real 10% of cases feature a second synchronous gallstone that dropped through that fistula right behind the first one. If you just take out the first stone, sew them up, and pat yourself on the back, that second sneaky stone is going to cause another bowel obstruction a few days later. You have to check the entire bowel, no shortcuts.
So we've tracked the anatomy of a disaster, decoded the radiologic clues, and navigated a very tricky surgical dilemma. This whole case brilliantly illustrates that in the heat of a medical emergency, aggressive intervention isn't always the hero. By doing an enterolithotomy alone and relying on the body's incredible ability to heal a fistula 50% of the time, we ensure our patient actually survives the night. I want to leave you with this final provocative thought. When faced with a complex, multi-system failure, could actively choosing to do less actually be the key to saving your next critical patient? Thank you so much for joining me for this explainer. Keep questioning, keep learning, and I absolutely cannot wait to unpack our next clinical mystery with you.